Okay, great. Thank you, everyone. Today, I would like to share some of the work that we've been doing at Einstein and Montefiore, building our research informatics platform, rationalize and explain to you why we did what we did, share some of our experience in terms of user adoption and utilization. Essentially, the take-home message is that we are inviting everyone to somehow find an interest to participate in this conversation with us to continue the development if you find it meaningful. So in the past 10 years or so at Montefiore Einstein, we've been building our dedicated research informatics and data science ecosystem. It is an ecosystem of multiple platforms to harmonize multi-source data, to create an analysis-ready data set, cast a net of privacy, policy, and compliance to allow us to broadly share and disseminate and democratize access to all of these data resources and provide tools that allows our investigators from both clinical translational research side of the house, as well as the hospital system and our learning health system side to independently do the analytics and data processing that they would like to be able to do, and of course provide some of the more modern larger scale analytic platforms to them. Today, we are going to only talk about the self-service components, but through the lens of that, you will also see some of the underpinning privacy and data management infrastructure that we've built for larger scale research. So very briefly, the intent was, as I mentioned, to scale accessibility and democratize access to all of our data sets, empower our investigators to do a lot of these things in terms of using EHR data for their research or for their operational use in a self-service mode as much as possible, and create tools, methods, and training that would elevate the culture and the literacy institution-wise in terms of how these data and analytics applies to research and operation. And the way we thought about doing it was to invest on existing open source frameworks. We have adapted OMAP as our common data model and build around it. We've adopted Atlas from the OHDIS community as our self-service component for RWE functionalities. We've used a lot of open source infrastructure to integrate missing NLP components at scale to complete the cohort-based study framework that can benefit from natural language processing and text understanding as part of the process. And again, we believe that the next step for us to be able to continue this development is to build a community around the tool. And I invite everyone to participate in development with us. So as I mentioned, we really used Atlas as the core of our self-service infrastructure for cohort-based studies. For this community, I don't need to explain what Atlas is. You probably know a lot about it already. It's a tool that the OHDIS community has created for cohort definition and computable phenotyping, and doing prep for research studies within the tool. And essentially, they have built it for collaboration to be able to create a standardized way and harmonized way of defining cohorts and sharing information, queries, and cohorts within a community. What we like about Atlas is its robustness in building a cohort using complex temporal relationships that includes multiple index events, observation periods, exit and entering criteria, very robust cohort definition framework that allows really robust cohort-based studies and real-world evidence studies within the tool and across multiple different study design frameworks. And it also comes with a lot of built-in analytics that allows doing a lot of common analytics on cohort-based studies. And it's what is nice about it is it also has a large library of shared analytics study designs that one can adopt, or your investigators can build and share these analytics with the community. So it's a very robust tool already for doing some of these analytics at scale. But there are a lot of problems in using Atlas as an institutional self-service tool. It is just not designed by design. Atlas is designed to promote collaboration between institutions. It has nothing to really support using this tool by clinical investigators inside a CTSA organization or in a healthcare system. It has significant usability and human-computer interaction issues for typical clinical investigators. It's just built for data scientists and informaticians for data scientists and informaticians from the UI perspective. Because of the collaborative nature of the tool, it has no governance, regulatory compliance, or no privacy tooling. It does not integrate with anything in your research informatics platform, does not talk to any of your existing tools and services that you may want to adopt. It does not provide extensive natural language processing and clinical text understanding facilities. And more importantly, it does not allow access to granular patient level, record level data in any shape or form. So it is not something that you can adopt as your tool of choice for a CTSA organization to focus internally in an academic medical centers or learning health systems use cases. So what we have done is to really bridge all of those gaps in a way that we can create a tool specifically designed for academic medical centers to open data at large scale with all of those privacy and compliance and other analytics. The most important contributions that we have done is to create an honest brokering service that allows the tool to work with fully de-identified, limited identified, or de-identified or fully identified data and traverse between them just in time. We have created privacy and public and private and team-based workspaces that can be also audited, tracked, and logged for compliance purposes. We have integrated to contracting and governance systems like data use agreements, IRBs, exempt workflows. So those workflows can be supported and enforced and audited through the tool. We have created interoperability frameworks, integrated natural language processing and data extraction tools that allows you to extract cohort-specific and design-specific data sets under the monitoring and as applies to your IRB, and a lot more. Those were the main features that we have developed, but we have also added really robust data quality, terminology services, MLOps, and real-time update mechanisms to underlying data so you can use it for varieties of research internally. I'm going to run through the slides very fast. There are a lot to say and show here, so it's going to be very superficial. Just to create interest, please contact me directly if you want to have a more in-depth conversation and a demo or a discussion. So I apologize for if I'm going to run very fast. So very first thing that we have done in Atlas is to redesign the UI with more than 100 usability and user experience enhancements to turn it into an internal looking software product, not so external looking collaboration specific one. So its primary purpose now is to support all kinds of clinical research, real world pragmatic clinical trials, quality improvement, process improvement, patient safety, patient screening, and research recruitment studies. inside an organization rather than just collaboration. So the collaboration is still there, but it's a bonus on top of everything that we can do internally with the software. And as you can see, there are features added to really make it specific to our organization, my use cases, and my data ecosystem at Montefiore. We have integrated to two IRB systems. As you can see, people can design reusable data baskets that they can use across their studies, and it is auditable. We can always look into who is touching what data when. It is linked to two IRB systems that basically approve protocols for different levels of identification, and the tool enforces and audits utilization of the data within those frameworks, and it allows access to data by the members of the study. It allows creating custom review processes. So if you do not want people to directly access data before somebody reviews their basket, reviews specific use cases before they actually extract data, it's also possible. In this screen, you can see that we have added a tab, which is an IRB tab, to existing standard tabs. We have followed Atlas's own GUI framework, so everything is fully integrated natively into Atlas, and shows that I have two IRBs of my own. I'm participating in somebody else's IRB, therefore I have access to this specific cohort, and I can add more cohorts before I touch them and do my studies in them. Everything in Atlas by design is public, but what we have done is to turn it around. Now, everything in our tool, which we call it search, because we've changed it so much that we don't want to confuse people by calling it Atlas, but it is essentially built on top of Atlas. So in search, everything is private unless someone makes it public. And in this screen, you see that we have created 64 public concept sets. We have basically imported them from N3C's validated concept sets, and we've built some of our own. And these are 4 public cohorts that I have access to. And as you can see, I have 166 cohorts of my own. Some of them are my cohorts, some of them I have access to because I'm part of somebody else's IRB that gives me access to their cohorts as well. We have extended the Atlas Web API to allow, and this is essential for our ability to do very fine-grained quality improvement, process improvement research, to basically align with specific institutional identifiers. Build cohorts based on this facility, this department, this section of the department, those very specific locations, providers that you probably are randomizing your patients based on, or you are creating a comparative analytics that will require segregating patients based on your institutional identifiers. It is now also possible within the tool, so you can design your studies as it fits your institutional setup and organizational structures. There is an online and automatically built catalog and data lineage service that allows people to look into every single mapping that gets into our OMAP, down to what source table those data points are coming from, what field of that table, what was the EPIC identifier, what was the EPIC label, was there any encoding at the level of your EMR, how did you code it to OMAP, and it is searchable, so you can actually filter. This is where the users go to see if the flow sheet that they're interested in bringing data is already in. And if it is there, how it is being mapped, how they can search for it inside Atlas. And it's not only in catalog. As you can see, we have created these inspect button inside the tools. So every concept you touch, not only you can see the record counts for that concept inside the tool, it shows that this specific concept, for example, the depressive disorder, is coming from 333 places in our EPIC. You can see what the codes were at the EPIC, what source codes, the ICD-10 codes we have mapped, and where exactly these are coming from. And not only you can inspect and see these codings and mappings inside the tool, you can filter based on them. For your research, you can actually, on the fly, at the query time, filter them out. So if, again, if this is a comparative study, if it is a quality improvement research, and you don't want to include certain mappings, you only want to include codes or records coming from a specific device in your institution, coming from a specific method of measurement that you want to include, you can filter those mappings out at the query level. This only impacts your queries and your cohorts, does not update the institutionally validated mappings. And you can suggest new mappings, or you can, if there are errors in the mapping that you identify while you are using data, you can report it, which goes through the cycle of data quality, and we fix those errors as community reports to us. Every time we give data to anyone, every time someone creates a cohort, they can look into the data quality on the cohort and the data set that they are extracting. So we provide an extensive set of data quality, fit for use, consistency, completeness report on every data set as we give it to people, not as the data resides at the source, which is critical for their ability to decide about fit for use of the data, or observe change over time of the data that they're receiving from the system as it pertains to their studies. As I mentioned, we have built a comprehensive data extraction tool. This allows automated extraction of data that aligns with their study design. So as they build a cohort based on inclusion criteria, exclusion criteria, temporal relationship within concepts, window of time that they are observing certain phenomena, it automatically extracts all of the data points associated for the kind of analysis that they're interested in. This saves days, if not weeks, of a programmer's or a statistician's time to make the dataset analysis ready. But it is done completely automatically here. It accommodates very complex chaining of events and creating windows of times that are connected to those events, creating blackout times, exclusion of certain data points, to the point that you create an analysis-ready dataset for extraction as it pertains to your study design. When they extract, they have option to extract it in 3 different ways. For data science pipelines that require large data sets that includes every data point, we create long views, which is the EAV format table. Wide view is a columnar representation that every patient is 1 row and every variable is a column. So you get all of the data associated with the patient in 1 row. It's a columnar view. Most people that do SAS or Stata or SPSS analysis, this is what they like. We create these pivots for them automatically. And for departmental use, where people want to follow up certain cohorts of patients over time, they're prostate cancer patients, service lines that are following up with different patients. We create a mini OMAP that automatically updates every day with the data that they want under certain IRB. So as long as they have a active IRB, they get a database that gets automatically updated inside a secured enclave that is centrally managed by us and gets audited automatically. Every time that data is extracted, we keep track of from what IRB to what patient was included in that data extraction or in that data update, which allows us not only to track from IRB perspective who is using what data, but also from the patient's perspective. If someone asks who is using my data for what purpose, we can basically look into every time that any specific data of our patients were used by anyone under what IRB, we can create those reports. And this is true across all utilizations, not just our self-service. Every data query creates these logs that is automatically traceable. As I mentioned, we have built a NLP infrastructure that is integrated to Atlas. It is, again, based on several open source frameworks that we have integrated, starting with Elasticsearch for really large scale real-time querying, and UMA and CTEX for concept extraction and encoding based on biomedical terminologies, with the facility to build your own custom NLP tools. And we have integrated our LLM infrastructure on top of that. We call our LLM Albert, after Albert Einstein College of Medicine. And it creates, again, a user interaction model that is fully integrated to our cohort studies platform. As you can see, you can bring your cohorts that you have built inside the cohort, tied to IRBs, and decide whether or not you want to basically adopt the design of the study, or you have a different time frames for queries in mind. Creates a workspace for you to decide what kind of notes and how you're going to manage your notes. We have built a robust querying language that allows building logical queries on top of text, down to encoding and extraction, linked with OMAP. I'm going to talk a little bit about how we do these encodings, and the visualization, a privacy-preserving visualization that integrates to the workflows. The query builder combines syntactic queries with all kinds of patterns and logical relationship between those patterns to terminology based on semantic querying. So within a single query, you can decide what is the pattern and what are the terminologies within those patterns that you're interested in. And it creates this language that you can basically, once you build and validate the query, you can call these queries from inside another service, another tool. It supports an interface that you can basically call for these queries from external tools as well. And once you extracted your notes, as you can see here in that query, we looked into 29,000 patients, and 151 notes were extracted with all of the details of operational use of these notes that you can further refine and look into what specific authors and what specific departments or processes you want to include or exclude, and create baskets for those notes that you're interested in. Visualizer tool, again, is designed to follow through the same IRB approved protocol. Everything is by design de-identified, but if you have a reason to identify, you can re-identify it just in time. We use large language models to do identification and de-identification in real time. And we have a multi-thesauri and custom terminology mapping tool that allows you to map it to whatever terminology of your choices. As you can see, we've also extended to map it to OMAP with all of the mentions that would allow someone to query the notes and update the observation tables inside your OMAP if you want to take these information and inject it into your OMAP CDM. Long story short, our self-service cohort management, cohort study tool integrates between natural language processing and cohort definition or cohort design frameworks that comes from Atlas. and you can create a workflow in which you build more specific, more sensitive cohort inside Atlas, send it to ElasTex to do more specific research based on the notes, push back those cohorts back into Atlas, do some more refinement, and do the cycle until you arrive at the most specific design that you want. And once you have a cohort, you can extract information based on it and do your analysis outside the tool, or you can share, do analytics inside the tool and collaborate with external entities as if these are just vanilla Atlas cohorts. But above and beyond that, because we have created the interoperability frameworks, you can bring your cohorts from everywhere they are. You don't have to build the cohort inside Atlas to do everything that I just showed you. And we use this interoperability to link between samples in our biorepository, images. A lot of our investigators follow certain cohorts within their own lab or in their own clinics inside REDCap. There are tons of cohorts and registries within Epic that we have integrated to our search platform, so people can bring their own cohorts and do data extraction for them, collaborate and share with other people, or do natural language processing on their own cohort based on where they find that cohort. And as you can see, it is fully integrated to Atlas. This shows my external cohorts that I have brought into this. There are 16 of them. 3 of them are actually made public. These are the cohorts from our biorepository that we've made publicly available for people. So if they want to extract clinical data or share those in patients and their information with other people, they can now do that. Throwing a tool as complex as this to the community is not really going to work unless you supplement it with a lot of training and support infrastructure. We have not only built tons of videos and documentation on how to do these things in a self-service mode. We've also collaborated with our friends in Tufts CTSA to create online, freely available learning opportunities. We have created a course that now we're offering inside our clinical research training program for medical students and fellows and residents that are taking that program. And we are also incorporating use of real-world evidence into medical students training program and so forth. So we really have supplemented the tools with a lot of training opportunities for our community to be able to understand what is available, how it works, and how they can consistently apply those tools into their research. A key question, we actually struggle with this question ourselves a lot, and I've seen every time that I talk about this with our colleagues, it also comes up. What would be the adoption if we build it, if we invest this? Will people start using it? Will this be accepted? And the tools that we've built, because we've been really consciously focused on usability, that was our first criticism of the Atlas the way it is. And the first 100 changes that we made to Atlas were all about usability. Is now paying back, as you can see. We started officially enrolling the tool from May 24, although we were working with some of the departments internally for creating a feedback loop and a test bed in operational setting. As you can see, we see a consistent adoption, and with the way we count unique self-service user is not people that have access or log into the tool. These are people that go through a very specific workflow. They design a concept set successfully. They build a cohort successfully. They generate, extract. They do something meaningful in the tool without calling for help. These are the number of people that we are calling as unique self-service people. People that do meaningful thing on their own without calling us. As you can see, it is increasing consistently. And now there are people that do multiple data extraction on their own. These are people that we should have actually done these data extraction for them, but now they do on their own. There are more than 120 as of last October cohorts that people are studying. And as you can see, there are a decent number of utilization. Every person in average has 15 cohorts that they are using, and there are more than 23 monthly data extraction that is being supported. How usable and successful the users are. This is our latest user satisfaction survey that we did not do. This is what ICTR leadership did, independent of us. So we had no role in playing these questions and questionnaires. As you can see, 81% of all users could do what they intended to do without having to go to someone else. And for a tool that I would say no one wanted to touch with a 10-foot pole, having somewhere between 80 to 75% satisfaction is a good outcome from my perspective. As you can see, we have scaled access utilization. We have been able to introduce new lines of service with the same workforce as the workload has come down.
I'd like to take the conversation a little more strategic. One of the challenges that we have at academic medical centers is getting our academic medical centers to buy into open source models. We've been running RedCap for years on the community MySQL service, and we needed to get backups done more efficiently. And before our IT would even touch MySQL, they required that we purchase the enterprise MySQL license so that they could hold someone else responsible and accountable for building, for supporting the kind of tools that were being built. And I feel like this is an ongoing issue in this space of software development, where we're all building tools independently, not interdependently, but independently. We've been working on what you've done for a couple of months now. You're much further than we are. I'd rather redirect our resources to create a collaborative coding infrastructure grounded in Azure DevOps across our organizations. That's all of interest, except when we get to the productizing of these things, we run into this problem of who's going to support it. And when we say there's a community of practice that supports this, the medical center doesn't want to put its trust in a community of practice to resolve a security issue. Have you given any thought to, I see all of these are technical.
Yes, we have some ideas how exactly the sustainability can be created in a way that open community gets what open community wants, which is free access, innovation, or fail fast way of building things in a way that we can advance the field, but also we can create support and sustainability infrastructure that the health system requires, from the security, scalability, all of those other nice things that a health system needs to see to adopt it. We have some ideas about it. We call it the open core model rather than open source model, which we think may, but this is hypotheses, but the more we engage with people like you to contribute to this ideation, the more ideas I'm sure that we are going to come up with. So we are looking into a model. We call it open core model. Other people have done this in the past successfully. We think if we adopt that, we can perhaps make some progress in that space. One of the key features that we did not even talk about was that we updated all of the obsolete libraries underpinning Atlas because we didn't even pass our own test, security test, when we wanted to show this to our own CIO to be adopted as our enterprise tool, right? Because of all of those problems. And it has passed the test in another institution as well. It's not just us. So we know that some of these work, but the question is, how you become credible enough and strong enough to support it in more than one place and attract more people to believe in it and contribute to it, which is something that we are very interested in.